Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Brett Rovin in Columbus, Ohio, with whom we would like to discuss treatment of lupus nephritis. Dear Dr. Rovin, it's a privilege for us to have you tonight. Thanks for being our guest.
My pleasure. I'm glad you invited me. Thank you.
Dr. Rovin is professor and division director at the Ohio State University Wexner Medical Center in Columbus, Ohio. He's not a leader, but he's the global leader in lupus nephritis, and his landmark studies on treatment of lupus patients have caused the renaissance of lupus nephritis in the last 2 years after a certain clinical stagnation in the preceding 2 decades. And together with Dr. Flöge from Aachen, Germany, he's chair of the KDIGO working group that wrote last year's glomerular GN guidelines, which have just been awarded as Kidney Paper of the Year by NephroJC. So we would focus our today's talk on guideline recommended and emerging treatment strategies rather than upon pathogenesis and diagnosis, which we broadly covered last year in our interview with Dr. Anders from Munich, Germany in German, and where fewer changes occurred within the last 12 months than within the field of therapy. And within treatment, we would focus upon class 3 and class 4 lupus nephritis, as class 1 and class 2 lupus nephritis do not often require kidney-specific treatment, and data on pure class 5 lupus nephritis are rare. I'm very happy to have 2 co-moderators who themselves are international experts in autoimmune kidney disease, Professor de Groot from Germany, Dr. Kronbichler from Austria, presently in the UK, who will discuss emerging and future treatment strategies. This leaves conventional treatment to me, and I would be honored if we would briefly review standard treatment in 2022 according to KDIGO guidelines. And I would purposely start with the medications that we as nephrologists often forget, namely antimalarials. You put some focus on this in the guidelines. You stated there are no large randomized clinical trials, but nonetheless, it's actually recommended for the vast majority of our patients. Now, the question from our part would be, with all the novel treatments, does this still hold true in the future, or should we really add this just to the conventional drugs?
Yeah, that's a great question, and I think that one of the things we forget as nephrologists is that we're also treating systemic lupus in addition to the kidney. And you know, my experience, as well as that of my rheumatology colleagues, we have a clinic together, nephrology and rheumatology autoimmune clinic, where we focus on these diseases, suggests that the background therapy with an antimalarial, which of course affects toll-like receptors, so there is some rationale for this in lupus, and really does take, if you will, in quotation marks, the edge off some of the non-renal manifestations. For me, what I've noticed more than anything else is that it helps control some of these nagging symptoms that patients experience when they seem to be doing better otherwise, joint aches and pains, and not really fatigue. Fatigue is a different phenomenon that we really don't have a good handle on. In terms of the kidney specifically, I think there have been pretty good studies. They haven't necessarily been in the manner that we would like all our studies to be, which is placebo-controlled, randomized, trials that are prospective. But the one I like is the Canadian withdrawal study, where patients had their hydroxychloroquine stopped after being on it for a number of years, and they tended to have flares, and a lot of these flares were pretty significant, including flares of lupus nephritis and even de novo lupus nephritis. So I think the trade-off of any drug, as we all know, is safety and efficacy, and the safety profile of hydroxychloroquine is really quite good. We do obviously require eye exams of our patients, and that is something that there's a lot of controversy around how often and what the exact dose of the anti-malarial is. But for the most part, I have very rarely seen eye toxicity. And so I think the balance is in favor of safety, and it does provide some efficacy. Some of the other larger trials, some from South America, have suggested that patients on anti-malarials are actually easier to treat in terms of their nephritis. And so whether that will remain the case with as we move to more novel therapy or not is really hard to say. A lot of the trials that we'll be talking about with the other panelists had hydroxychloroquine on as background. And so my personal preference is that I start all of my patients on hydroxychloroquine unless there's a specific contraindication.
And one other thing about background treatment, what about SGLT2 inhibitors? Now, we are all fascinated by their study data. However, most randomized clinical trials so far did not really include patients on immunosuppression. So how do you do with your lupus patients? Do you generally put them on SGLT2 inhibitors?
Yeah, so this is really a topic that needs to be investigated, and we are with other partners trying to set up a trial to look at SGLT2. As you know, and I'm sure I'm not the only one, as you know, there's been no lupus patients were purposely in the large SGLT2 trials. And, you know, for me, again, we need to look at the kidney sort of holistically. And in that sense, we want to look at, you know, preservation of kidney function, not simply treating proteinuria. And I do think there may be a role for the SGLT2 inhibitors. That said, I don't think that precludes or should take over or interfere with the use of immunologic mediated therapies when the disease is active. So at the present time, to answer your question directly, when I believe that the patient no longer has any disease activity, and we are prone to biopsy those patients to show that, almost all of these patients have chronic kidney disease, right? Even histologically, if not really measured by eGFR, which of course is not a very good measure of renal function in these young patients. If they do have chronic kidney disease and they're no longer being immunosuppressed, then I will put them on an ACE inhibitor. Of course, they're usually already on that, and an SGLT2 inhibitor. And I've done that with a handful of patients in my lupus clinic, and I really can't comment on how it's going other than it's well tolerated, and I haven't had many withdrawals because of side effects. I haven't had enough experience to say whether that's really made a difference or not. I will say, and I'll love people to challenge me, the data are based on some of the data that were a post hoc analysis of the DAPA-CKD trial. We're waiting for the EMPA-CKD trial, as you know. And, you know, we treated a lot of patients with IgA nephropathy, and it showed a benefit. But if you look at the data closely, the eGFR benefit was pretty minimal. And so while the SGLT2s, I believe, have a role, I'm not entirely sure that the deltas that are being touted for these drugs is really going to be seen when these are really out in the public use in a very large population. So a tentative yes for specific patients, and then the idea that we need to study this in diseases like lupus and ANCA-Vasculitis and other diseases which result in chronic kidney damage.
So when switching to immunosuppressive medication, and when hearing your talks, and there are great talks on KDIGO meeting from you virtually on YouTube, I get the idea that you do no longer actually like the subdivision into induction treatment and maintenance treatment. KDIGO guidelines still have this subdivision. Yeah. Should we kind of leave this and come to a more continuous approach, or what are your recommendations on nomenclature?
Yeah, I think the nomenclature is confusing, and I actually always have thought it's confusing even before we now use trials or are using medications that really are continuous over the long term with these patients. I think, you know, induction to me, coming from, you know, training and a world where cancer has used the word induction, has a very specific meaning. And the truth is, at the end of quote induction treatment, a lot of patients really aren't in a complete remission. Okay. And to prolong cyclophosphamide until they get into complete remission is probably not a good idea. And so we and others have shown that most, you know, if you consider induction therapy within the first 6 months, 3 to 6 months, most people start to have their complete remissions at around 9 months, and that continues out for a number of months. And so what I prefer to think about is initial therapy for lupus nephritis that includes something, and we're talking about proliferative here mainly, that includes a big anti-inflammatory regimen. And I think that's really important because that's the primary pathophysiologic event that's injuring the kidney at the time. Concomitant with that, I think we do have to start immunosuppressive medications to control the background ongoing autoimmunity that these patients are prone to. And therefore, starting something at the same time as an anti-inflammatory, and the only one we have at present really for lupus is corticosteroid, it makes a lot of sense. But then that's a continuous treatment. The idea is to control inflammation, back off on that control when things do come under control clinically or histologically, if you will, if you do a repeat biopsy, and then continue on something to control autoimmunity. And often we start drugs, you know, and that's been mycophenolate and cyclophosphamide, all at the same time, thinking that this is exactly what these drugs are doing during induction is treating inflammation. And the point is that I think that mycophenolate and cyclophosphamide do control inflammation, but much more slowly than glucocorticoids. If you remember the very old studies, they're not that old to me, but I guess I'm getting older. The studies from the NIH, you could control lupus really well for a long time with just glucocorticoid. The problem was that these patients started to lose kidney function after 3 to 5 years, almost certainly, in my opinion, almost certainly because they continue to have ongoing autoimmunity with ongoing hits to the kidney. And so the addition of a cytotoxic agent at the time, cyclophosphamide, was almost miraculous, right? Because it preserved kidney function. And again, I think all of us seem to be a little bit influenced by the way clinical trials are designed, in which the primary endpoint, of course, is complete renal response, which is driven almost all by proteinuria. And what we really want to do is preserve long-term kidney function. So I do like this idea of sort of thinking about the treatment of lupus nephritis as a continuum: inflammation, controlling autoimmunity, and then, as you suggested, do we have to do specific things to preserve kidney function because we have damaged the kidney in the process of treating an inflammatory disease? And then the SGLT2s, the aldosterone antagonists, and of course, the angiotensin converting enzyme inhibitors are important.
For the steroids, you actually give 3 options. So you have the standard dose option, the moderate dose option, and the reduced dose option, which is one of the first novelties really in these guidelines, to go for lesser steroid treatment. So would the reduced dose actually be the standard that we should aim for, or what gives us an idea whether to use the standard one, the moderate one, or the reduced one?
Yeah, so this is really a great question, and if you ask my opinion of the lupus guidelines 2022, and of course, just for the audience, and I think everyone knows this, the guidelines took years to prepare, really, with discussion and deliberation, et cetera. They were written almost entirely prior to the approval of any of the new medications. So with that in mind, we did try to include some statements about the new medications, but we included all 3 steroid regimens. Now I'm giving my view, my personal view. The data, the way I put it together, and the biggest difference between these guidelines and the guidelines from a decade ago is that we have started thinking about using a lower dose of steroids. And I think that's a benefit for all of our patients. And I would guess that you all have experienced the same thing as me, which is patients may take the drug and then stop taking it. They don't like it. The side effects are difficult. And I think that contributes to the large non-adherence we see in the lupus population. And that, of course, affects everything down the road in terms of getting control of the disease. I think that if you properly treat the patient with a large dose of methylprednisolone at the beginning, that we can then reduce the dose of glucocorticoids considerably. The methylprednisolone at the beginning acts very acutely to start to control inflammation. It does so for a prolonged period of time, and and then the other agents which will affect inflammatory cells and immune cells will have time to kick in. The data that support this are several fold. I'll just bring out this study from Liz Lightstone's group in London at the Hammersmith, where she used no oral glucocorticoids, but 2 doses of methylpred, totaling 1 gram at the beginning, with rituximab and then mycophenolate all added. Now, you can say, well, the rituximab did something quickly, but we know that that's not true. That might be something we discuss later with obinutuzumab in terms of the rapidity of disease control. And you can say that the mycophenolate was added right up front, but again, that's lesser immunosuppressive. My suggestion is that between 1 and 1.5 grams of methylprednisolone at the beginning really does make a very good impact on inflammation right from the start. And then you can start to reduce the dose of oral corticosteroid that you give the patients. Now, our group has adopted that sort of protocol, and we use, I think, the middle regimen from the KDIGO, which is sort of a dose of 2 doses of methylprednisolone over a couple days, followed by about 0.5 milligram per kilo per day of oral prednisone. We don't use prednisolone very much here, and then really reducing the dose like they did in the voclosporin trial. We're playing with that. I will do that when I have all these other drugs on board. But in using just standard of care therapy, we start with 0.5. Now, we do taper it very rapidly. Okay, we do taper it rapidly a la the voclosporin sort of tapering regimen over the first 3 months. And I think that's of a benefit to the patients as well. So that's sort of the way I think about approaching glucocorticoids. And of course, ideally, we will minimize glucocorticoids going forward. That should be a goal of our therapy. And now you did ask another question, would I consider high dose in specific situations? Traditionally, when a person has an RPGN and they're sort of deteriorating very quickly, we tend to throw everything at them at once. Is that necessary? Well, we're never going to have the data to know whether we can get away with a lesser dose. I suspect it's overkill. I know that when a long time ago, I call it a Rovin meta-analysis because I'm not a statistician, but I gathered as much data as I could find published and or from individual investigators that they hadn't published. And I sort of tried to understand whether you could use mycophenolate versus cyclophosphamide for a rapidly progressive severe lupus nephritis. And my conclusion was you could. But I would, even members of my own glomerular disease group here, if a person has an RPGN, will use high-dose cyclophosphamide. So there are situations in which we as physicians may feel more comfortable. Is that absolutely necessary and evidence-based? I'm not sure.
So the next major change is actually that you shifted from 4 standard immunosuppressive regimens to just 2, the low-dose cyclophosphamide and the MMF option. You just alluded to some patients who might benefit from higher dosage of cyclophosphamide. So if we discuss these 2 standard options with our patients and giving the advantages and disadvantages of both options, I think all patients will actually go for the MMF option. Do you see, in addition to those patients that you just mentioned, with really severe disease, patients that may still benefit from cyclophosphamide? And indeed, in the guidelines, you briefly hint at this, that the long-term outcome may be somewhat better in those who go initially with cyclophosphamide.
Yeah, so that's really, we never did a proper, in my opinion, long-term study of starting with mycophenolate and cyclophosphamide. The ALMS came close, if you remember, and the follow-up data, even though it wasn't statistically significant, suggested that those patients on cyclophosphamide at the beginning actually did better. Now, I think these days we may be able to modify that with all the new drugs. So that's number one. We are, in our group, a cyclophosphamide prone group for a number of reasons. As you know, we were big advocates of oral cyclophosphamide and had been using that for years before we sort of adopted the Eurolupus regimen. I do think intravenous cyclophosphamide is an option for patients, and especially those patients in which adherence is an issue. These are by and large young people. They don't want to be sick. They've been healthy their whole lives, and convincing them to take pills every day, and there's a lot of pills, is really sometimes quite difficult. But you're right. When you describe the side effects of cyclophosphamide and mycophenolate, even though the studies show that the number of adverse events is the same in both groups, they're just different kinds of adverse events. Most people would choose mycophenolate, and we have come around to that idea in our group. And I will say that the majority of folks are started on mycophenolate, but we evaluate them, and if they're not really responding adequately, then we will switch to cyclophosphamide. And as I said, we tend to give higher doses of cyclophosphamide, more the traditional NIH regimen, in those patients who are really, really sick and rapidly deteriorating. But this is really, you brought up a great point, which is the patient needs to be involved in the decision-making process, because if they really are involved and buy into the decision, then they are more likely to take the medications and really work with you rather than, not, and then get into trouble. So I think that's really important. And as, again, coming back full circle, as we now have more things that may preserve kidney function over time, is the small difference between what we saw maybe in the ALM study and some of the other studies sufficient, or will some of these newer medications like SGLT2s help us overcome that and sort of really equalize long-term outcomes? And I think that remains to be seen, but I'm positive about that. I mean, I'm not positive that that will happen. I have a good feeling about that being the case.
So the last question from me before switching then the mic to Dr. Groot would be the maintenance phase. Again, you give 2 options, MMF, which is somewhat better than the traditional one, azathioprine. And that surely always the question comes, should we really stay on 3 grams of MMF, or can we reduce the dosage? And even more important, when can we safely stop the maintenance treatment?
Well, that's a whole.
Nobody knows. I'm aware of that.
Yeah, that's a whole several hour discussion. Okay, so we prefer mycophenolate in all our patients. We even, the Euro lupus regimen specifically targeted low dose cyclophosphamide plus azathioprine. We don't do it that way. We use low dose cyclophosphamide followed by mycophenolate. The tolerability of mycophenolate is generally pretty good. I realize there's GI symptoms, and then we go to myfortic or mycophenolic acid if that's the case, and we generally can keep people on it. I reserve azathioprine for those patients in whom they cannot tolerate mycophenolate. They really are hoping to become pregnant, but really I want them to be in a good remission before they become pregnant, and I usually then have time to switch from mycophenolate to azathioprine. Those are my thoughts. I think the data are really quite good that mycophenolate is superior to azathioprine, but azathioprine, all said and done, is not that bad. So we can switch between, depending on tolerance or situation. Now, your other question is really profoundly important. No, I don't keep them on 3 grams. When I have a remission where I'm happy with the level of proteinuria having declined and the creatinine declining, and it usually takes about a year or so, then I start to come down on the dose of the mycophenolate. And these days, I'm generally not starting patients on 3 grams of mycophenolate. That's awfully high. Not most patients probably don't need that dose. My top dose most of the time is about 2.5 grams, and then I come down from there. The question of how long to stay on maintenance is critical. And as you know, we have been trying to answer that question with a repeat kidney biopsy regimen, which is well tolerated by patients. Not ideal, of course. We want to have biomarkers to tell us what's going on. But the idea is that if obviously you've been in a you've had a patient in complete remission for a long time, clinically, how certain are you that you can get rid of the medications, albeit slowly? And we take the medications off slowly, to be honest. And we don't know that. Clinically, a lot of the patients will have a complete histologic remission as well, and they'll do fine. If they continue to have activity on their kidney histology, they have a higher chance of relapse. And of course, with each relapse, there's chronic damage accumulation in the kidney. So what we hope to do is by making people aware of this, we can increase the use of the kidney biopsy now to help us make this decision. But ultimately, the goal will be, and I think we actually now have some biomarkers that are ready for testing, not necessarily ready for prime time by the FDA definition of a biomarker, but need prospective testing. The idea would be we would monitor patients going forward with a biomarker of tissue activity. And when that tissue activity has decreased, or the biomarker has gone down, if that's the direction it's going in, then we could in real time start to consider tapering the therapy. Nonetheless, what we do know from the repeat biopsy studies is that activity is present for a way longer period of time in the tissue than we appreciate clinically. And so to me, there probably is a basement, or some sort of finite time that we have to treat the patients. And I don't think for most patients that's only a year of therapy, even if they do remarkably well. Right now, we're saying at least 36 months of total therapy, and most patients have more than that. Can it be lowered in some patients? Absolutely believe that's possible. just we have to understand which are the right patients to do that in, so we don't create trouble.
Now we have seen the standard therapy, and in the last, let's say, 5 to 7 years, the concept of a multi-target therapy has emerged. And basically what we do is we use MMF plus a calcineurin inhibitor as the induction treatment. And I agree that induction treatment in lupus is not a very nice wording, because it takes a long time. That's completely different to, let's say, ANCA-Associated vasculitis, where you really see a remission mostly within 6 months. That doesn't happen in lupus. The kinetic of the disease is completely different.
Yes.
But would you probably explain to us what the calcineurin inhibitor does, how it acts in lupus nephritis? What is the idea behind the calcineurin inhibitor?
Yeah. So the calcineurin inhibitor, ostensibly, of course, as we all know, is a T cell drug, and we use them in transplant all the time. And the T cell signature is present in lupus and lupus biopsies when we actually look at the transcript level. And we know that T cells and B cells work together to make autoantibodies, and we know in particular in lymphoid follicles, T follicular helper cells are important in generating the autoimmune response. So I think there's really quite a bit of rationale, and I'm sure Achim went over some of these things on his talk. There's significant rationale for targeting T cells. And I must tell you, we've really avoided targeting T cells in sort of a conscious way in lupus for many, many years. Although obviously steroids, glucocorticoids do affect lymphocytes, as does cyclophosphamide and mycophenolate. But so you can say the overarching idea is that this is going to hit an arm of the effector immune system that we may not have targeted very well in the past. So that's sort of an underlying rationale. The other rationale, I think, that's really very important is this idea of podocyte protection. And this of course, as all nephrologists know, there's really 3 main effects of the calcineurin inhibitor. The hemodynamic effect is there, and you see a small decline in EGFR that's usually quite reversible. And proteinuria may decline a little bit because of that. Is that really impacting the kidney over long? Probably not. But what I do like is this idea of trying to protect and preserve the podocyte cytoskeleton, because we know from Roger Wiggins' work that if we lose podocytes and we lose too many, no matter what you do, that glomerulus in that kidney is destined to go to end stage. And I think that's something that we have not really appreciated in diseases where inflammation has been our major focus. But I really like the idea of protecting the podocyte, and these studies, mainly done in other diseases, diabetes is a big one, looking at podocyte in the development of glomerulosclerosis, podocyte loss in the development of glomerulosclerosis, should be taken to inform us in all of our diseases in which the glomeruli are affected. We know that the podocyte is injured in the lupus nephritis patient. Maybe we don't have diffuse podocyte effacement like we might have in minimal change disease or primary membranous nephropathy, but you certainly see the podocyte injury histologically. And there's data from murine studies and murine lupus that were fascinating, looking at, and they were treating mice with tacrolimus or placebo to look at how the number of podocytes was stabilized in these lupus-prone mice, how the slit pore density was maintained, and how the synaptopodin, which is critical, of course, to the actin cytoskeleton and the structure of the podocyte foot processes was preserved. So I am firmly convinced that this is a benefit of the calcineurin inhibitors beyond simply the T cell. And this again goes to this whole idea of preserving kidney mass in a functional way to keep patients off the need for renal replacement therapy. So that's sort of the way I picture this. And of course, the downsides we know for the calcineurin inhibitors are the propensity for interstitial fibrosis and nephrotoxicity. But again, you know, we see very commonly in transplant population, which is not a lupus population. One kidney, increased, maybe increased glomerular pressure, hypertension because of one kidney, denervated kidney, et cetera, et cetera. If we use the calcineurin inhibitors for a 1-year period of time, you know, I'm not particularly worried that we're going to see quite a lot of nephrotoxin nephrotoxicity with these drugs. So I think that's something to keep in mind, is duration and what our background is. So really that's the rationale, and I think it's not an unreasonable rationale.
Now you have published a trial using a special multi-target therapy in that you used mycophenolate plus a new calcineurin inhibitor, voclosporin, with a slight rapid taper of steroids and mycophenolate plus steroids in the control arm. Could you probably depict to us in what way voclosporin is different from cyclosporin A or tacrolimus, or what the advantages of that novel drug are?
Yeah, so that trial, of course, was the Aurora trial, and the trial itself was unique, of course, because of the very rapid and very low starting dose of the glucocorticoid. And I think that was a bold move. It has been criticized, saying that this disadvantaged the placebo arm. And I just want to comment, you know, we do have data from a propensity comparison of patients in the ALMS trial who received full dose steroids and full dose mycophenolate, that this regimen was not substantially different than what we saw in the ALMS trial. But nonetheless, to answer your question directly, what are the advantages of this new calcineurin inhibitor? So there's a few advantages that we know of now, and a lot of those are metabolic advantages. So we don't see diabetes. There's no propensity for diabetes that you see with tacrolimus. The drug dosing is much more predictable, or the drug levels are much more predictable than with the other calcineurin inhibitors. So ostensibly you don't have to measure levels. And the truth is, clinical laboratories don't measure levels right now. I know you can get them measured at Aurinia, for example, but that's not done clinically. There's also metabolic advantages in terms of lipids and probably of electrolytes. The big question is, are there advantages in terms of nephrotoxicity? Because that's what most people are concerned about. And of course, we don't have those data right now. Although that is being looked at. I think that there are some hints that there is potentially less nephrotoxicity with voclosporin. There's been a comparison in animal models. I was reading about rabbit experiments, and apparently rabbit kidneys are particularly susceptible to calcineurin nephrotoxicity, which I did not know until I started looking into this. But using voclosporin compared with cyclosporin, and you know, they're very close. There's just one molecular moiety difference between cyclosporin A and voclosporin. But the animals that got the cyclosporin had a rise in their serum creatinine, and with 2 doses of voclosporin, the serum creatinines were stable at their baseline. So that suggests, at least in that particular model, there may be less nephrotoxicity. Human studies we don't have. There were a couple of comparisons looking at patients with transplant who had received cyclosporin, and then patients with transplant who had received voclosporin. And there was, of course, a finite incidence of nephrotoxicity or decline in GFR, or rise in serum creatinine in the transplant patients, and that was not seen in the voclosporin treated patients. Of importance with that study is that they were different patient populations. This wasn't a head-to-head comparison. So you take that as you will. You know, those are not strong data. And then the last bit of data, which I found pretty interesting, was looking at changes in patients with psoriasis, because calcineurin inhibitors are used in psoriasis, and cyclosporin and voclosporin have been used in patients with psoriasis, and the decline in GFR in the voclo patients, I believe, was much less than what we saw or what was seen in the cyclosporin patients. So taken together, they do not provide proof or even our best level of evidence that we want that the calcineurin inhibitors don't cause nephrotoxicity, but they're suggestive. And I think we have to at least think about that and design studies going forward to look at that. Now, there are data that were presented, I believe, at the ACR. I don't think they were at the ASN actually, of the extension trial with voclosporin up to 30 months. And we do now have data up to 36 months that are being prepared for presentation or publication. But at least the data that are present in the public domain looked at the GFR over time, because the patients in the Aurora study were maintained on their voclosporin for 30 months, and their GFRs did not decline over time. Now, that is not an absolute, of course. That's good, but you know, histologically, we don't know what's happening, and of course, we can have plenty of fibrosis before we start to see a decline or an increase in the serum creatinine. So that's what we have right now, and those are. I really think those are things we have to work out in the future to see whether there are other advantages. But those are the advantages we know of now.
Absolutely. Is there repeat biopsies thought about in the voclosporin group? Because that would be a way to find that out.
Yes, of course. And really, when we were talking about the design of the trial, I and others really insisted that we put in a repeat biopsy portion for the Aurora study. And so we did get repeat biopsies on several patients, and I'm happy to say they're being analyzed right now. In fact, the data, some of the data were sent to me. So we hope to start to put these together and look at the histology and then get this out to the community so that they can see if there's been any changes in histology in the voclosporin treated patients. But absolutely, that was something we insisted on, and that was the way the trial was designed.
Now let's come to the primary endpoint. The primary endpoint was a composite endpoint that had to be met at 1 year, consisting of proteinuria level, decrease in EGFR, rescue treatment, and we have seen that the voclosporin group has fared much better and achieved the primary endpoint significantly more often than the patients in the control group. Now, this is, and if you analyze the composite parts of the composite endpoint separately, we see that this endpoint has been severely driven by proteinuria.
Yep.
Is that, would we think that this is a very good endpoint in the long run, or wouldn't we want to aim for a hard endpoint like doubling in serum creatinine or renal survival or whatever we use for SGLT2 inhibitors, for example?
Yeah, this is sort of the crux on which we have to start thinking about how we design trials, and you know, part of the repeat biopsy study is not only to assess whether damage has occurred, but I'm very curious to see that the inflammation is under control, because these drugs have lots of effects on things that cause proteinuria, like the podocyte, or when the podocyte's damaged. So yes, absolutely. All our endpoints are driven by proteinuria. It's an imperfect marker. And what I think we've seen in the last few years is that we can do successful lupus trials, like the BLISS-LN and the phase 2 Nobility trial, with 2-year endpoints where we actually can look at a GFR. And I think somehow we're going to have to start to think about incorporating those endpoints into our assessment of novel therapies. I think it's important that, you know, we understand the FDA considers the complete renal response, and that's a variable definition, but they all circle around sort of the same as a something that can qualify a drug to get a label. But then I think we need to do, you know, follow-up studies to look at GFR to really inform us how to use these medications appropriately and really what they do over the long term. I don't think we're ever going to go to the really, really hard endpoints of end-stage kidney disease. It takes too long, or doubling of serum creatinine. But some of the other endpoints that are being used in other clinical trials of glomerular disease certainly are applicable here, and that's slope, delta slope in GFR, and amelioration of the slope, or amelioration of the number of patients who sustain a 30% or 40% decline in GFR, which are harbingers of poor long-term kidney survival. So I think we have to start thinking, as we design the trials, of, you know, the 1-year endpoint, if you will. That's what the FDA has obviously accepted, and then look further into how we continue the trials with extension studies, or design the trial with 2 different endpoints at 2 different points in time to look at GFR. And I think that's absolutely necessary, because that's essentially what we want to do with our patients, is preserve their renal function.
Absolutely. I think that's great. That's a good way to follow, to look at these endpoints. That has been a problem in lupus nephritis all the way along, to choose the ideal endpoint. I've got 2 last short questions, and possibly because time has progressed and we steal your time from you.
A pleasure to be here.
The pleasure is on our side, I think. What would you reckon, what is the flare rate, or what do you expect flares when you take patients off voclosporin 1 day? Have you got an idea on that?
I don't have an idea. I mean, you can criticize the extension study of the Aurora, because they, you know, the Aurora was, everybody was kept on the voclosporin to see sort of how they did. So that's one way of doing it. The other way would have been stop the voclosporin to see what happens. And I think a lot of us are worried about the flare issue, because we're so used to treating patients with primary membranous or FSGS with a calcineurin inhibitor, and then as soon as you stop it, explosion. Now, why I don't think that's going to happen is because the patients are on additional, as you called it, multi-target therapies. So I do think that this will keep the disease in check. And I think essentially this is really a different disease because it's not entirely a podocytopathy like some of the other diseases. And I realize membranous is an autoimmune disease as well, primary membranous, but it really primarily affects the podocyte without a lot of inflammation. So I think this is probably going to be okay, but I don't know that, and it certainly is an important question. I agree. Okay, and my last idea is there was a limit to the estimated GFR of 45 milliliters per minute for patients to enter the trial.
What do we do with those patients? It's not so often, it's not so frequent in lupus nephritis that patients enter or have the first visit with a very bad creatinine, but we see these patients, and we have a communal renal biopsy club, and we just discussed a patient of ours that came when we saw her first. She had a GFR of 30 milliliters per minute. Now, what do we do with this patient?
So, again, this is not what the label says, but we're all nephrologists on this call, and
we all, I agree.
Yeah, we all play with these drugs and use them in patients with much lower GFR. The label says 45 because we have the tolerance of the FDA, and it's a very cautious sort of approach, which I understand, and that's completely appropriate. Same thing with the SGLT2 inhibitors, right? They said you couldn't use them below a certain GFR.
But they've come down to 20 now.
Yeah, but I've been using them much below what was recommended from the beginning, because we know we can watch the patients very carefully. If a patient has a severely impaired GFR, I mean a severely impaired GFR, I probably would not start on a calcineurin inhibitor right away. However, as you probably know in your own patients, really, as you start to treat these patients and clear up some of the inflammation, that GFR starts to improve fairly quickly. And I think we can add a calcineurin inhibitor in then. However, if a patient were to present to me with a GFR of 40, not 45, I would have no hesitation to use a calcineurin inhibitor, even below 40. Would I follow that patient more closely and follow their serum creatinine? Of course. If that patient had a lot of scar on their biopsy, because we usually have
all acute inflammation.
Yeah. If this is all acute inflammation, yeah, that's different. But I use all the clues that I have available to decide whether it's safe or not to use a calcineurin inhibitor. And sometimes I see the creatinine go up and I have to take them off, but a lot of times it's just fine. So that's really where sort of the following your clinic procedures really come to bear, and the patient has to come up and get the blood tests.
I thank you very much. I started her on the NIH regimen and with the option to change over to a multi-target therapy. That was my approach, but
yeah, I think that's fine.
Thank you very much. I hand over to Andreas.
Yeah, thank you so far. And I have a couple more questions about the future of therapy. So one question is basically taking us back to the LUNAR trial. And it has shown that rituximab has a delta of at least 10% in favor of rituximab efficacy. So part of sample size calculation, the failure of rituximab, are you still using rituximab in your practice? Because for us, it's working here quite well.
Yeah, it works for everyone quite well, but me, I guess. So I use rituximab, and we just got a paper out talking about a little bit about rituximab, sort of as a salvage therapy. I think that my personal experience with rituximab has been more sort of a coin toss, 50-50 in terms of its efficacy. And I think part of the problem is as you are, I think, alluding to, and we may talk about the future, is rituximab is good if it depletes B cells completely and rapidly. And that happens in some patients. There's a lot of reasons why rituximab may not work as well in a particularly active lupus patients. One of them is the need for complement to help get rid of or kill the B cell, the CD20 cells. And I like that explanation. There's other explanations, of course, as well, because we tend to think complement is an important component, and being consumed in really active lupus can take it out of, use for rituximab. So I think that's an issue. I think that the post-hoc analysis of the LUNAR showed much better response in those patients who had ostensibly complete B cell depletion. And of course, we all know that this is a clinical lab grade flow cytometer. We're not getting complete B cell. The other issue, of course, is where are the B cells being depleted from? And we only look with flow cytometry at the not at the tissue level, but at the circulating level. So I think that the renaissance, if you will, for B cell therapy may be upon us. But we do use rituximab, and for patients who we've exhausted other therapies. I very rarely start it as the first line therapy, despite my understanding of Liz Lightstone's trial and my agreement that her approach was quite good. One of the issues, of course, is insurance and getting the drug because it's not approved for lupus. Although if patients exhaust, in the United States anyway, if we show patients have exhausted other treatment, we can appeal. And insurance generally will help us get rituximab. So that's sort of my short vignette on rituximab, but I sense you're going towards a different drug.
Yeah, that's the next question, basically. So after nobility, what would you expect from the phase 3 Regency trial of obinutuzumab?
Yeah, so and just for your audience, just for transparency, I've worked on all of the trials that we're discussing. So I've worked with these companies and have been an scientific advisor for them. So I don't think it's biasing my approach, but just so everyone knows that. The nobility study was very exciting. The difference in the B cell depletion kinetics between obinutuzumab and rituximab are stark. And obinutuzumab depletes very well, very quickly, much more rapidly than rituximab. It doesn't really rely on complement as much as rituximab did for killing. And there are data from the cancer literature that suggest that tissue penetration, I'll use that word, that's probably not the correct word, but there are certainly B cells and T cells aggregating in the kidney, and maybe they're helping to form on-site autoimmunity. And so I think that the idea of tissue getting into the tissue and killing B cells is important as well. So the obinutuzumab trial showed very nicely that B cell inhibition was possible and actually had a good effect on outcome. Now, that was a complete renal response, proteinuria, and the thing that you saw was that it took a while, right? The curves of the two arms started to separate at 6 months and then continued to grow apart. And that's important because, the B cell drugs seem to take a little bit of time to start having their efficacy. And I think that this will bring okay, so you asked me specifically what I think the phase 3 trial is going to show. I'm confident that the phase 3 trial is going to replicate what we saw in the phase 2. I really do think the data for the phase 2 were robust. And I think that this drug will probably be on target to gain approval for lupus nephritis. And then you will have to figure out how, now you have 3 regimens to use. That's going to be sort of interesting for us to decide how to use them. But I think that, you still have to sort of have the initial push towards controlling inflammation, because it's going to take several months for the obinutuzumab to sort of kick in. And I think that's important. But yeah, I do think this is really going to be an important development for us to use. And I think then it's going to probably push rituximab out of this space.
Yeah, I certainly agree. And this leads on to the next phase 2 trial of the recently published anosogromatic disease paper of anifrolumab anti-interferon inhibitor, basically missing the primary composite endpoint, but showing very good response rate if you just subdivide it. What do you think? Is there a future for interferon blockade in lupus nephritis, or do you think it's with this drug?
No, I think there is. Okay, so I was very excited to participate in this particular trial. I think this idea of interferon being a central in the pathogenesis of autoimmunity in lupus is really important, and we see time and time again, our studies, other people's studies, this interferon signature, and it's really robust when we look at the transcript level, when we do microdissection of the glomeruli and the tubulointerstitium. So I do think there's a story here. I think the trial clearly showed that we have to be cognizant of target in the tissue we're looking at, and achieving depletion of that target. In this case, the lower dose of the anifrolumab did not really deplete or attenuate the interferon, type 1 interferon signature. And so if you're not hitting your target appropriately, then I don't think we can expect it to be efficacious. The higher dose did. The trial will go forward. The phase 3 trial is going forward, and I think that that this will be important. Now, when I think about where this is, you know, I like to be very simplistic in how I think about the disease, and of course you have systemic and possibly renal autoimmunity that's because you're predisposed genetically, and then you have an appropriate environmental trigger, let's say. That's one way of looking at it, that starts it off, and then you start to get, you know, damage or inflammation in the kidney, but you don't realize it until it's sufficient that it's really causing damage, and that can be quite a ways down the road. You know, an interferon drug right there would probably be pretty effective, okay, as a preventive. Now, you can say, well, then that requires us to know when people are starting to head towards kidney disease. And I think that's an excellent question. And that's something we want to investigate, because getting ahead of the game is really, I think, important. Okay, where, you know, is an anti-interferon type 1 anti-interferon drug anti-inflammatory? And I think probably it is, because interferon, type 1 interferon drives a lot of the effector cells down the road, but it's a couple of steps removed. So is it going to be instantaneous like a glucocorticoid? I don't think so. I think that this is another drug that is going to help more on the systemic autoimmunity side with a little bit of inflammation. So I think we have to plan the trials to look at what we expect the drug to do, and think about the pathogenesis of kidney injury in lupus nephritis. And I think when we start applying these ideas to our drug design or our trial design, we're going to have longer trials. We may have shorter trials if something's particularly good in an anti-inflammatory way. I'll just give an example. I don't know if you were going to talk about the new drug that was a complement drug that was for, you know, ANCA vasculitis, but that's, to me, an anti-inflammatory drug that can act right now, right? So different mechanisms of action, I think, are really important to consider when you are planning a trial. Not every trial should be 1 year proteinuria endpoint.
Yeah, and in the next couple of weeks, we will have David Jayne with us in the same round to discuss steroid replacement refinement in ANCA vasculitis. So coming back to the most recent standards for us, basically, you have published a very nice article with Isabella Ayoub in Kidney International, taking together all the trials and proposing a risk score. So if you have a high risk patient based on this risk score, eGFR, high proteinuria and stuff, what is your approach? Are you more towards a multi-target therapy, also combining, for instance, cyclophosphamide, steroids, and a third treatment arm for these patients? Or what are your thoughts about that?
Well, so there's two ways I look at it. One is, you know, since we're we're at an academic center, we're trying the new therapies. We're trying the new therapies to learn as much as we can about them. And we're not necessarily using that particular paper to decide, okay? What our group is trying to do is to understand how to use belimumab, understand how to use voclosporin, et cetera. I think that in general, we don't know how to use the new drugs, and we need to now start diving into which patients they'd be appropriate for. I do think that for most lupus that's out there in the community, generally it's sort of mild to moderate. I think you might agree, with exceptions, of course. Those patients may do very well with current KDIGO standard of care, mycophenolate plus steroid. I do think, though, that what we outlined in our review article that came out not too long ago in KI is sort of an approach to this. And I don't think it disadvantages the patient, which is, start out with a therapy that you're happy with and comfortable with, and that would be whatever standard of care is by the KDIGO. And then if the patient is not progressing in the fashion you expect, and you set up, sort of landmarks that the patient has to hit that are within the short term, then switch. And my sort of recommendation is to consider one of the new therapies. The thing that I think is interesting is the new therapies seem to piggyback onto the older therapies without disadvantage when you look at the post hoc analyses of these trials. And so that gives you a little bit of wiggle room. So I don't think you're necessarily hurting the patient. Now, your question is spot on, which is we need to do studies that will identify a priori the patient in whom you want to start with an aggressive multi-layered therapy right from the beginning. Or another way of putting it is, who are the easy patients that are going to respond well to sort of minimalized therapy? Because, these drugs are now approved by the FDA. They're likely to become standard of care, but that's really aggressive. And, you're adding a lot of immunosuppression. I realize the data for safety look pretty good, right? And we know belimumab has a long track record of safety in patients with lupus. So those are good signs, but nonetheless, you're adding a whole bunch of stuff to people who already take a whole bunch of pills. And, they're already not very adherent to those. So you have to sort of take all these things into consideration. And the last thing I'll say is, we do have to be responsible as physicians for the cost of healthcare, I think. And the new medications are costly, and they're not going to be available throughout the world or to all populations. So we're really starting to see some divergence now, and we have to think about, how we could best apply those drugs, and even in places that might not have easy access to these medications, if you can make a case that this particular lupus patient would really benefit, and they're a young person with a lot of years left that, will help society and life and everything, then maybe we can justify getting those drugs on a limited basis. So I think there's a lot of things that these new trials are raising that are not simply medical or scientific. They're also social and economic issues, and we have to be good custodians of those resources.
Yeah, I think this is a very important point for most countries, the cost calculation. Coming back or moving forward the next couple of years, and this is my last question. So you are aware of the report in the New England Journal of Medicine of a patient treated with CD19 targeted CAR T cells, very successfully refractory lupus patient, and especially these patients are usually not responsive to a magnitude of therapy. So do you think that in 5 to 10 years, all our patients will be treated with CAR T cells?
Well, I think CAR T-cell therapy will be probably reserved more for the really difficult patients in 5 to 10 years. Beyond that, you know, I think that a lot of the side effects we see with the CAR T cells, which are major, right? I mean, in the cancer patients, are when they're killing this abundant population of cancer cells, like the cytokine release syndrome, and maybe this very bizarre neurotoxicity that these patients get. So I was fascinated by that report. I know it, as you said. There is thought to potentially looking at this in patients with refractory lupus nephritis. I think that will it become a standard therapy? I'm not entirely sure about that, because when you think about it, you know, if you're going to use autologous cells, like is mostly done, you know, there's a period of time where you have to take those cells out, treat them, grow them, and all this other business. And you can't, if a person's really sick, you can't necessarily wait that long. Now, maybe they would be added later, and that might be beneficial. There's some question of using other donor and just having, you know, CAR T cells off the shelf, which is interesting, but that raises this question of graft versus host disease or host versus graft disease. So I think there will be a lot of things to work out. But when I think about refractory lupus nephritis, just using that as a starting point for answering your question, I think we have to be really cognizant that there's probably very few patients that are refractory or refractory. If you go back and question them and really work with your patient, at least in my population, a lot of them aren't taking their medication or not taking it appropriately, or we've dosed it inappropriately. We really don't have good guidelines. We have these fixed dose regimens, right? And we don't know if that's one size fits all. The truly refractory patient, I think, you know, this is an interesting therapy, and that was a remarkable case report. And so I do think it's probably worth looking into, to tell you the truth. But I don't know that it's going to become standard within that short time frame that you gave.
Dr. Rovin, on behalf of all our German, Austrian, Swiss colleagues, thanks so much, not only for this academic hour, which was really a highlight for our YouTube channel, but also for all the publications of the last years. So the coin side is that you will have to revise your brilliant guidelines quite soon, I guess. And surely for really an academic life in lupus nephritis, which helped the treatment for these patients and which really allowed us here in Germany, Austria, Switzerland to do better with our treatment. Thanks a lot and have a nice afternoon in Ohio.
My pleasure. And yes, the very first topic we're revising for the KDIGOs, because it's a living document now, is lupus nephritis.
So we come back to you one day. And
yeah, maybe.
Yeah? Thanks a lot. Yeah,
okay, take care. Bye-bye.
Thank you.
Bye.